So, hello everyone. I'm Louise Cobain. I'm the Assurance Director at MIA. Anne Heighton normally chairs the meeting, but unfortunately she's on a train to London this morning and was a little bit worried about her signal dropping in and out. So I'm just going to chair today's meeting, but I think the main focus of today is a session from Jamie Foster and Sally Barr, both from Hill Dickinson, on insourcing clinical services and procuring extra capacity from consultant LLPs. So Jamie should be joining us shortly. So I was just going to mention a couple of other things while we're just waiting for Jamie to join us. A lot of you will have seen the request from Stefan at Langston South Cumbria FT yesterday around, has anyone got a partnership work and service development policy? So I suppose just if anyone can support Stefan on that, if you could get in touch with him. Also later on this morning, if we should be expecting Mike Gill from NHS Providers just to come on briefly. He's really keen for comments and input from GARNet members around the potential development of a risk practitioner course that's being jointly developed by NHSP and the Institute of Risk Management. So I think Mike might be coming on about 10 past, quarter past 10, or he may be on early. So again, we're really keen for your thoughts on that. And then I suppose all of you, I don't know whether you're aware, on the Futures platform, there's been a discussion around holding a session on system risk management, and that's tomorrow, Friday, 25th. I think it's Michael Spicer from one of the London ICBs is facilitating that. So again, just I suppose if anyone was interested in that, get in touch through the Futures platform with Michael Spicer. HF and May are going to be involved as well, I think. So hopefully we might get some guidance out around system risk management, which would be really, helpful. Well, there's lots of people coming in now. Has Jamie joined us?
Not yet, Louise. I'm keeping my eye out for him.
Okay. Sally, if I hand over to you just to do introductions, and then I don't know whether you want to make a brief start, or Jamie may have come in by the time you're ready.
Yeah, that's great. Thanks, Louise. So just to clarify, Jamie's from Hill Dickinson. In fact, I'm the Managing Director of Trust Health. We work with consultant partnerships throughout the UK, but we also work very closely with Hill Dickinson. So we're doing a joint presentation today on what an LLP is, how the model works, and then Jamie will cover some of the legal side of it. I have got a presentation, our joint presentation, so I will just bring that up. Okay, can everyone see that? Yep, perfect. Yes. Okay. Jamie would normally do these slides, so I will just whiz through the first few of them, the introduction part. So we're going to be talking about procuring extra capacity from consultant partnerships in trusts and how the model works and the things you need to look out for. Just a few housekeeping things. Please keep your microphones off and cameras are automatically switched off, I believe. The session is being recorded. If you have any questions, please can you pop them in the chat box and we'll answer them at the end of the webinar. These are Jamie's slides. If you have any problems with sound, please try logging off and rejoining, checking your device. And please ensure you have disconnected any monitors connected to your laptop or computer. And also feedback's important, so please complete our survey when we send that to you at the end. And then what we will cover, so LLPs in practice, and then Jamie will talk about procurement rules, managing conflicts of interest, and also the contracting arrangements and what you need to look out for in particular. The context of this is that the elected backlog has prompted Trust to consider ways of looking at extra capacity. As we all know, waiting lists are through the roof, and consultants tend to be reducing their working extra work because of the pension tax. So the LLP model is a model that's been used for many years now. Trust Health has been going for 17 years, and we've been promoting and working with consultant models throughout that time, consultant LLPs throughout that time. So it's not a new model, but it's becoming much more commonplace now. And it can be used as a long-term solution as well as a short to medium-term solution, depending on what the trust requirements are. So what is an LLP? An LLP is a limited liability partnership. It is a legal entity incorporated with Companies House. But overall, the model is a very flexible model with limited liability. So it's got the best of both worlds. It's got the best of the limited liability you get with a limited company, but it's got the ease of administration internally that you get with a loose partnership. So it comes together and works very well for professionals in particular, particularly clinicians. Usually, it will be the consultants in a trust, for example, would be the members. Not only the one trust, but usually the consultants own the business, and that provides an engagement that you don't find elsewhere when you're contracting, for example, with some of the national insourcing, outsourcing companies, depending on which way you call them. The LLP can provide additional theatre or outpatient sessions using the spare trust capacity. And usually they would employ the whole theatre or clinic team. I'll cover a bit later the different scenarios and type of options that our LLPs provide. But the idea is to help the hospital treat more patients, reduce your RTT, and improve clinical pathways as well. And it is a cost-effective model for the trust because you will be retaining surplus from tariff, particularly if you're outsourcing work or using some of the large national companies at the moment. What are the benefits for a trust of working with an LLP? So essentially, a key part is that the services are provided by your own consultants and staff. You need to liken this with using the national company. The national companies, most trusts are using those to a certain degree and bringing in staff. But having an LLP using your own staff means that they're familiar with your policies and procedures. There's continuity of patient care before and afterwards, so they can do the ongoing care, particularly for inpatients, but also they see the patient before and afterwards as well, and they know that how your governance works in your trust. Incentivise and engage the clinicians in the pathway. So we find often that the LLP work is more efficient for a number of different reasons, and that is because they're incentivized. The consultants own the business and they're incentivized to make this work. And we also see that flowing back into their in-job plan and work as well. Because they own it, they want it to work. It's their business, they want it to work. And you get engagement because there's peer pressure amongst the consultants. So if 10 consultants own a business and there's an issue, you might have an issue with one of them, there's peer pressure from their colleagues to make it work and they fall into line. If not, they're expelled from the LLP. They can also attend MDTs and communication with other specialty consultants. This is particularly relevant for things like radiology, where we find a lot of the reporting for the outsourced companies has to be re-reported, and particularly there's no attendance at MDTs. Efficiency improvements up to 25%. Now that is when everyone is being paid on a per procedure, per patient basis. You see improvements of up to 25%. It's not that the clinical time goes faster, it's the downtime between seeing patients disappears because everyone wants to work more efficiently together. As I said before, 100% consultant-owned business results in the optimum engagement. It absolutely does. If they're working for some of the other outsourcing companies, then they're an employee and they have no say or no rights in how it works. That they're engaged in making the model work. The important point here is that the trust retains control over the service delivery. So they're your patients, they continue to be your patients from beginning to end, but you're just buying in the LLP services for part of that patient pathway. So the patient sees no difference. And they're not told that they're being part of their patient pathways from an LLP, so you retain control over the whole service delivery. Costs are linked directly to performance, so you pay for what is delivered by the LLP. You're not paying for activity that doesn't take place. Staffing flexibility. The LLPs who employ staff, the staff are employed by the LLP, and therefore they're not bound by agenda for change rates. This means that the LLP can pay them in a different way than the trust is able to pay them, and it will motivate them and incentivise them to work more effectively together. And the vehicle is a flexible vehicle for you to manage and plan capacity. You can be looking to do this long term if you have long-term aims for this, and when we're managing the work, we would usually be looking to book patients 3 months in advance, so you know where you are. But it can also be used as a short term as well, and most of the contracts that we have they're like a tap, so there's no volume associated with assigned to the contract. You can just turn the tap on or off as and when you need some additional activity supplied by the LLP. The different activity options. So these are the type of models that or contracts that we've got agreed with our LLPs. So it could be that the LLP provides the whole theatre session or the whole outpatient session. And that could be just the provision of the surgeon, or it could be surgeon and anaesthetist, or it could be the whole theatre team or the whole clinic team. So it depends on what your blockage is. What is your pain point as a trust, and the LLP needs to be a solution to that pain point. So there'll be no point, for example, in the LLP saying we're going to provide surgeons only, when actually you're holed up with extra activities that you also can't get the theatre team, the staff in the theatres to work as well. In which case it would be better for the LLP to provide the whole team. If, however, you have the whole theatre team already and they're happy to work extra and there's no problems with that, then provision of a surgeon maybe and or anaesthetist may be sufficient. If you have particular issues with regard to efficiency and the volume of work that takes place, say on overtime on a Saturday, you may wish us to go through the LLP and for them to employ the whole team, because everyone only gets paid for what they do, and if they don't deliver on the patients, they don't get paid for it, which is usually different from the models that trust pay. The sessions can be weekend, weekday evenings, or backfilling during the weekday. So if it was consultant only, surgeon only, that would often involve lots of weekday backfilling for sessions where you've got the anaesthetist and you've got the staff already. But if you're looking to supply the whole theatre team, that often takes place in the evenings and at weekends. But again, it's depending when you've got capacity and what your particular issue is as a trust. As I said before, most of the contracts are no contract commitment, so it's a tap you can turn on or off as and when you need extra capacity. So if you decide that you don't want to work with the LLP for any reason, you don't have to give them any work. There are various payment options. We recommend usually that per procedure patient rate is best for efficiency, but there can be sessional pay as well. There can be reasons for that, particularly if it's trauma or if it's very complex patients that vary in the time of each procedure. It's not predictable, so sometimes a sessional pay for that as well. It's coming up with the aim is to come up, and the point of success is to come up with a model that works for all parties. So how does it work in a typical model? What would happen? Going through the stages, the trust has identified that it requires additional theatre activity, for example, to reduce the patient backlogs. Could be clinics as well, but it's usually theatres. There's a reduced uptake of WLI work as the rates aren't viable because of the pension tax implications for the consultants. So the trust identifies spare theatre capacity and approaches the LLP. We have numerous discussions with both parties. Sorry, I should have gone back to what we do as a company. So we're contracted by the LLP to provide business support services to them, and that is to help them get set up in an LLP to start with, but then also to help them negotiate the contract with the trust. We know what works because we've done this for so many years. The fees have got to work within tariff, and we know all the rules around sort of and the difficulties you might need to overcome with things like IR35, contracting, procurement, those types of things. So we sit alongside both parties to negotiate a contract, and then we provide the ongoing business support services for the LLP. They pay us to do this. The contract is between you and the LLP, so they pay us separately if they want us to do the invoicing, the ongoing contract management meetings, all the financial breakdowns for and the payroll for all the staff, and that side of things. So we're aiming to provide a sort of a one-stop shop package of services for them, so they can focus on the clinical care. So we put together a proposal for the trust, having sat with both parties and identified what the issue is and what they can do to resolve that issue for you. Discuss the proposal, discuss the fees with you, discuss how you want to do the contract and the procurement. You may, of course, get Hill Dickinson involved or other lawyers to get the legal side of things, but we work also closely with Hill Dickinson. After going through the negotiations, we agree a contract for service provision between the parties. Sometimes trusts use a standard subcontract, other times they use Hill Dickinson have drafted a subcontract for LLP work in particular that sits back to back with the main NHS contract. So it depends on each trust what you want to do. There's usually a pilot that's agreed for around 6 months to get it up and running started, and then a review at the end of the pilot. I would always say, though, that this model is only going to be successful if every party is happy. So regular discussions, open dialogue is really important. There may be issues that you foresee are going to come up, but they need to be talked about. It doesn't work if it's kept, behind the scenes. It needs to be open dialogue. And then if there's open dialogue, the model tends to work very, very successfully. These are a few common operational questions from trusts. Will it create a perverse incentive and your in-job plan work will be reduced? The answer to that actually is no. I understand it is a common question. We would say to all trusts that you would need to look at your activity levels that you've got taking place at the moment in job plan work and continue to monitor those. If there are any indications that this is happening, you would need to discuss that with the LLP chair and ourselves, and we need to identify why that is. If it's one particular individual misbehaving, then that individual would be spoken to about it, and they would either fall back into line, or they would be expelled from the LLP because they're bringing the LLP into disrepute, and that's part of their members' agreement that they all have to work together to promote the best interests of the LLP. In actual fact, it doesn't happen. We haven't come across it happening. Will it affect in-job plan staffing levels? So one of the concerns is if the LLP, for example, employs your theatre team on a weekend, on the Saturday and Sunday, will they then call in sick and they're not going to be around to work during the week? We can have a contract in the staff, a clause in the staff contract with the LLP that states that the members of staff, if they call in sick on an NHS list after they've worked for an LLP, won't be able to work for the LLP for the next 3 weeks. Again, in reality, it doesn't happen because the people who are working hard, the staff who want to work hard, are the ones who will do the work, and they're not the people who are likely to be calling sick and putting a fast one. So again, that doesn't happen, but it's a genuine concern, and understand that. What happens about beds? Yes, a common question, and the bed capacity does change, obviously. If beds are an ongoing issue, we often start with inpatients, with day cases, and the day case model works very well. The LLP can provide all the team for, if you have an autonomous day case unit, they can provide all of the team, including admissions and discharge for that day case unit, so the patients can all go home. But we can usually overcome some of the bed situation, even if it's less inpatient work intercepted with lots of day cases. And can I run this for all of my in-job plan work during the week? Probably not for now. The issues would become that the staff would then all need to be employed by the LLP, and that's probably a step too far for the LLPs to take, that all the staff would need to be 2P'd over, and it's a complete step change for the LLPs. So probably not at the moment. However, we do see that the benefits of efficiency at the weekends, if everyone's working through an LLP, then filter back also to be taking place during the week as well. So we do often see that as well. So it's a sort of a win-win for the trust. Okay, I've done my part now, and now it hands over to Jamie. So I'm hoping that Jamie has come onto the call.
Yes, good morning, everybody. Yeah, I'm here.
Hi, Jamie.
Sally, I've been listening in. Brilliant, thank you. I guess people may have questions at this point. I don't know, Alison, if now's a good point just to have a break for any questions.
Yeah, just one come up from Dillis there about quality and outcomes.
Oh, here's a few questions. Yeah, okay. What about quality and outcomes? Again, the quality of the work and the outcomes can be monitored by the trust in the usual way. So we would recommend regular review meetings, regular contract review meetings, where the quality and outcomes is discussed. At that point, it's a discussion for each individual trust how they want to do that, but absolutely that would be monitored, yes. But all the patients follow the usual governance within the trust. The policies and procedures within the trust, they're not being outsourced like they are with some of the large companies where the patient goes onto a different system. The patients are on your system being treated in your hospital, and therefore they follow the usual policies and procedures and process with regard to quality and outcomes. But we would recommend review meetings, yes, where they're discussed. Can the model be used to address gaps in rota? Yes, absolutely. Yep.
Any more questions off anyone, or can we move on? Oh, there we go. I think we're okay to move on, Jamie.
Okay, brilliant. Oh, I think Sabina had a question there.
Yeah, I just wanted to follow on from my question. So our concern is that at the moment, obviously consultants pick up extra work to cover gaps. And if we put this model in place, they're going to stop doing that and they'll do it through the LLP. And obviously that would then cost the trust more. And I just wanted to just talk through that with you, because obviously that was a concern, that this will open the doors for all other areas, all other specialties in our trust to do something similar and set up LLPs.
Yeah, I mean, if you have consultants already filling the gaps, then you may not need to have an LLP for that particular role.
They're not filling all of them, that's the problem. They're just filling some of them.
So the question is, would they fill more of them if they were doing this through an LLP, or actually would they not? Because sometimes there are just more sessions and the consultants want available than they actually want to do. There is always a concern that it will open the doors to lots of LLPs. In reality, we haven't actually found that. What the specialties that tend to start are orthopedics, and I think it's probably because of the type of work they've got, the type of they're quite business orientated usually, and the work is quite predictable. It's routine and quite predictable work. So orthopedics would often start. There are other few specialties that do also work, but usually so a trust might commonly say, well, if we start it for orthopedics, what about, are we going to be inundated with requests for multiple LLPs? What happens is most people, it is a business. And you've got to run this bit, they have to run the business, and most consultants actually don't want to run a business. So what they can do is they can work, if they come to a trust and say, well, you know, we want to do this, the answer is, okay, away you go, you come up back to us with a proposal, and set your business up, and then come to us and we'll discuss it with you. But in reality, what happens is the other specialties tend to join the orthopedic, or the one of the largest specialties that set up the initial LLP, and work through them, so they can work as subcontractors through the you know, let's say the orthopedic LLP. So you haven't got multiple LLPs. You tend to, I mean, we've got one trust that's got 3, and that's the most that we've got. Other specialties are working through the larger LLPs.
Okay, that's great. Thank you.
Okay, no more questions. Sally, I wonder if it's worth me sharing my slides, because I don't think I can take control of yours.
No, that's fine.
Hopefully if I...
Yep.
Have you stopped sharing yours?
We can see yours.
Ah, okay, perfect. Yep. Great. Well, hi everybody. For those of you that don't know me, I'm Jamie Foster, a partner at Hill Dickinson in the commercial health team, working on all kinds of commercial projects for trusts and other clients. As Sally's alluded to, this is something that has been very topical for a few years now, but is becoming ever more topical at the moment, really. So Sally's talked you through the sort of commercial and operational ways in which this model works. And what I wanted to do was just talk you through the sort of legal and governance risks, because one of the questions we're always asked by trusts is, well, we like the idea of this because this will help us with the challenges we're facing, but can we do this? Is this a problem from a governance point of view? The simple answer to that is yes, you can do this. You know, there's no legal barrier to this. There's no current NHS guidance that says you must not do this, but there are various things you need to consider. And that's what I'm going to talk about now. I think it's fair to say that a number of trusts, lots of the trusts we work with, have decided that although there are risks in this, the potential benefits outweigh the risks. And there's no doubt that lots of trusts have put this model in place. It is a common model, not without its complexities, but it is out there and operating successfully without being challenged. So hopefully that's a reassuring message for you. If we look at the legal framework, then I think it's worth just starting by looking at what this is legally. Hopefully you can see that slide. I can't actually see my slides on the screen, but hopefully that doesn't matter. What is this model legally? Well, NHS England has, in some cases, called it insourcing, and the definition there describes what they've put in their guidance about insourcing. I think there's a bit of insourcing is not a legal term, and there is some debate about whether this is actually insourcing or outsourcing, and in some ways you could say they're the same thing. Usually insourcing is defined by the fact that an outside supplier comes in but uses the trust assets, so uses the theatres, the equipment, support staff. But actually, often outsourcing works like that to some degree as well. So I'm not sure it matters too much. The definition is relevant to some extent when you look at IR35, the off-payroll rules, because if something can be defined as outsourcing, then it falls outside those rules and you don't need to worry about IR35. So I think there's a bit of ambiguity around this. It doesn't really matter. The point is, it's a contract that the trust awards to an LLP or a company set up by clinicians to deliver services. That's legally what it is. It's a contractual mechanism. And in that sense, it's a subcontract. So the trust is commissioned by its ICB, and then it subcontracts to this service provider to provide the service. And it's very important that this contract is an arm's length contract. And that's really helpful for a number of the issues that come up: procurement, conflicts of interest, and IR35. The more you can show that this is an arm's length relationship and it's not a relationship, a sort of, if you like, cozy relationship between the trust and the consultants or clinicians, then the better protected you are. So that's what it is legally. And we can, I don't know if everybody could mute their microphones. I'm hearing a bit of noise from somebody's. There we go. So the first thing to look at is procurement. So public procurement, almost always the first thing that people ask, well, how can we just award a contract to a group of clinicians who set up a company? Does that not trigger procurement concerns? Procurement is definitely something you need to look at. Procurement law is changing, but the current law at the moment is up there, the public contracts regulations, which I'm sure everyone's familiar with. And broadly speaking, where the value of the contract is above the threshold, the light touch regime threshold of £663,000, then you have to run a full-on competitive process. If it's under that, then you've got a bit more flexibility to run a light touch process. But before you get there, Trust will obviously look at whether an exemption applies. And there are a number you can look at. One is that you've tested the market and there are no responses. No one else out there is able or willing to provide this service, and that's often the case if it's quite a specialist service that only a group of clinicians in a particular area can deliver. Another one is that this is the only capable provider when the services can be supplied only by this provider. And the third one is urgency, but it's very unlikely that you'll be able to rely on that. That was the exemption that was used a lot in COVID, and even in COVID very quickly was thought to be something that couldn't be relied on. So we can rule that one out. In most cases, what a trust will look at is, first of all, is there a framework that we can draw down from to award a contract to a provider? And a framework is a pre-procured list of providers, and it allows the trust to call off. There are a number out there at the moment that I've listed here: the insourcing of clinical support services, supplementary healthcare services, and the increasing capacity framework, which to one degree or another could potentially be used for awarding contracts without having to worry about procurement process. You need to look at the terms of each of those frameworks. You need to see if they are open at the moment for new applicants to get onto them, because often consultant LLPs will not be on these frameworks. But if they are, and there's an opportunity to get on them, then you've got a really easy answer to the procurement question, because you can just direct award from the framework. But as I say, often consultant LLPs or companies are not on these frameworks, so you need to look at whether you have to run a competitive process. So in practice, what that means is, first of all, assessing the value of the contract that you might be awarding to the group, and who else, based on your knowledge of the market, is out there potentially who might be interested in the service as well. And then think about whether, if it's over the threshold, as I say, look at frameworks, decide that you need to run a process, or simply make a direct award, relying on that only capable provider exemption, and just take the risk. Take the risk that you are going to be challenged, and that you'll be able to fend it. And in most cases, trusts have made direct awards to providers. One thing that's very relevant to that is the procurement law is about to change, as I mentioned, and broadly speaking, to make it easier for direct awards of contracts. So lots of trusts have said, well, we'll award a short-term contract, say a 6-month to a year contract, to our consultant group. And that will allow us, first of all, to pilot it and to check if this is a model we like. And secondly, if we were to be challenged, to say to the market, well, look, at the end of this short-term contract, we'll consider our procurement options, and we may well go out to the market. And that's usually enough to head off a challenge. So the reality at the moment is that most trusts have gone down the direct award route, have not been challenged, but have done it on a short-term basis, taking account of the fact they want to pilot it, and that there is that the value of the contract is low enough that it's not likely to be challenged. Does anybody have any questions about procurement? Often people do. No, that's good to know. Sounds like everybody's well versed in procurement. So I think, yeah, the message there is that it's not necessarily a barrier to this. So I mentioned the NHS procurement rules changing. This is a slide just about the provider selection regime, which is going to replace the public contracts regulations. And it's designed to be flexible. It's designed clearly to still make sure that taxpayers' money is spent properly, but to provide more flexibility where there are obvious reasons for making a direct award to a particular provider, and for then continuing with that contract over a period of time because you're happy with the service being provided. So that is due to come in. The date hasn't been confirmed yet, but we understand the aim is that will come into force in perhaps April next year. So it's not too far off. So if you were to award, say, a 6-month pilot contract now, then by the time you look to renew that or award a new contract, we would hopefully be into the provider selection regime, and you would have a better justification for rolling over that contract. So that's the procurement position. The next issue that often comes up is conflicts of interest. And there's an obvious potential conflict between, and this does sometimes arise, between the trust awarding contracts to its own clinicians, particularly if any of those clinicians or other people, non-clinicians working for the consultant company or LLP, also have a role in the trust allocating work. So in many cases, it's not only the case that the trust is looking to put everything through a consultant LLP. It might be that they have other providers that they use depending on what exactly they want to procure at a particular time, including for the same services. And where that's the case and an allocation process happens, as well as an allocation process around numbers of sessions and things, then it's really important that, for obvious reasons, the person making that decision within the trust does not have an interest in the consultant LLP as well. So that's the most obvious way in which this is relevant. There are a few detailed slides here. I won't go through them all, but you can have a look at them when we circulate them, just to remind everybody about what the rules are for NHS bodies around conflicts of interest. I'm sure this is a well-rehearsed topic, and the aim is not to go through it in detail, but suffice to say, you need to comply with the various guidance. You need to bear in mind at all times the purpose and the principles around conflicts of interest: openness, transparency, integrity, and probity. Be clear about what a conflict is, and the definition here is useful in that sense, and when a conflict of interest could arise. So financial, non-financial, which can be both professional and personal, and then indirect interests as well. So it's a wide definition of conflicts of interest and what an interest is within that. So you need to bear all of these things in mind and make sure a proper process is undertaken to make sure there are no conflicts and they're being managed properly. This is just an example of some of the matters that should be declared that are fairly straightforward there. And what does this mean in practice? Well, you can look at different ways of dealing with conflicts. I think, as everybody probably knows, conflicts of interest do not automatically mean that someone can never take part in any discussion or decision about a particular action, but there's a range of options that can be considered. So you need to look at all of this, ranging from restricting people's involvement in decision making where they've got a conflict to outright excluding them. And ultimately removing them from a role if there's a very significant conflict, as might be the case if someone was allocating work to outside providers of the kind that the LLP would be undertaking. So in my experience, conflicts of interest hasn't really come up as a very sort of live issue on these models, but it's definitely one to have in the list of things that you need to consider as you go forward. Just a couple more slides here about examples of where conflicts arise, and a reminder of the breach consequences, which are potentially serious, and another reason why it's very important to consider these issues carefully. And yeah, it wouldn't be a lawyer's set of slides without a picture of the Royal Courts of Justice. That's the only reason that's on there, of course. But the breaches are very serious, so do make sure you follow the conflict process when looking to award these contracts. And the last area is contracting, and I mentioned that it's really important that the contract between the trust and the LLP is an arm's length arrangement. That's what makes sure that this is as protective as it can be for both the trust and the LLP. So the benefits of contracting on an arm's length basis are, as I say, it protects both parties. It's not the case that it protects the trust but not the LLP. The contract fundamentally includes commercial terms but also mitigates risks for both parties. So really important that a good contract is in place. It puts the arrangements on a sustainable long-term footing. From an audit purpose, it's clear that this is a properly awarded contract, and it can be contract managed, audited, renewed, or terminated as you would with any other contract, which obviously is much harder to do if you're putting in place an informal arrangement of some kind. From the LLP's point of view, interestingly, it allows them to compete for other contracts because they hold a contract and they can potentially go off and bid for other contracts out of area in the knowledge that they do already deliver a contract. It sets them up to be able to do that. We haven't seen a lot of that, but in theory, that is possible. And you might start to see that with bigger LLPs and with some of these models that are commissioned on an ICS wide basis, not just on a trust basis. And we started to see that as well. And from the trust point of view, clearly it allows it to consider the LLP in the context of its wider medical workforce needs. So the more this is seen as a sustainable medium to long-term solution, notwithstanding a short-term initial contract, the more the trust can use it as part of its planning and can start to recognise that this is something that can be built into workforce planning and needn't just be a particular solution to a problem at a particular time. So there are obvious benefits to that. So what is an arm's length arrangement? Well, the features of it are that it's a legally binding contract. It's not an SLA, and lawyers will tell you that an SLA can still be legally binding, but in the NHS, as we know, SLA is shorthand usually for something fairly informal. But this is a legally binding contract, and we'll come on to the form of that. It transfers risk to the supplier. That's an important factor in demonstrating that this is outsourcing for the purpose of IR35 not applying. The contract will provide that either that the supplier provides its own staff and equipment, and we know that staff will be provided through the arrangement. More commonly, and for very obvious reasons, the contract will have a schedule of services where it sets out what the trust is going to supply. So access to the theatres or other facilities, equipment, support staff, whatever it may be. And it's really important that that's documented in the contract. So again, it's not just an informal arrangement. It's really clear. You need to look at this on the basis, if you were contracting out to, for the sake of example, Capital or Sodexo, you would put that into the contract, and you need to look at your contract with the LLP in the same light. Because you're doing that and they are being contracted with, the supplier will also need to look at what registrations it needs. So there's CQC, and in some cases, LLPs have gone off and got their own CQC registration. In others, the CQC has said it's fine, you don't need to, you can rely on the trusts, but that needs to be considered on a case-by-case basis. Registration with the ICO for the purposes of data protection. The supplier should have its own policies. Now, they may, of course, look very like the trusts, but the more it can demonstrate it has its own policies, the more it can demonstrate that it's a standalone service provider with whom it's appropriate for the trust to do business. And insurance, of course, but as long as the LLP is being contracted by the trust, then and it's using the right model form of contract, which we'll come on to, then it should be able to access the trust's NHS resolution indemnity, so it won't need to go out and get its own. So all of those are the key features of an arm's length arrangement. The form of contract, as I say, needs to be legally binding, and we recommend that it is in the NHS standard subcontract form. So as I'm sure you know, trusts do not have to use the NHS standard subcontract when contracting with clinical suppliers. It's not a mandatory document, but it's highly recommended for the simple reason that it passes down and flows down the risks and obligations that the trust has to its commissioners to the supplier. And as Sally mentioned earlier on, what we've done is developed a version of the NHS standard subcontract that can be used for an arrangement such as this. So, for example, we've included a schedule where you can put in what the trust services are, which equipment and facilities the trust is going to make available. So that's the best way of contracting, and that's not a huge piece of work to put that contract in place because most of it is in standard form. The only bit that needs a bit of reviewing are the sections which have been tailored for this model. The contract terms will obviously be set out in the standard subcontract. That's what you use. I've just listed them here. Everything you would expect. The service specification is important because you want to be clear that the same quality standards and requirements that the trust commits to the ICB, it requires the LLP to commit to as well. So there's no gap between the level of service. That's really important. The trust needs to be able to contract manage the LLP if services are poor for any reason. Reporting is important. There'll be indemnities in there to protect both parties. And as I mentioned, clarity around registrations, policies and insurance. And of course, the contract will also include the payment terms that have been commercially agreed. So all of that is a summary of what you need to do to put in place an arm's length arrangement. And that's very relevant to IR35 risk, as I've mentioned. There are a few other terms here that are worth mentioning from an IR35 point of view, all of which help to evidence the fact that this is a form of outsourcing, and that IR35 does not apply because the consultants supplying services through the LLP could not be deemed to be employees of the trust when they're providing these services. So one is that, and this is a really important point, the trust is contracting with the LLP to deliver services. It's not what you might term an agency arrangement where it's a contract to supply staff. It's supply of services. And the key to that is the trust is agnostic about who is supplying those services. So there'll usually be a list of the consultants who are working within the LLP who will be available to supply services. But the contract is not one in which there's an agreement that consultant X will supply services for session Y. It's simply a contract to supply services, and it doesn't matter who is available to do that. And that's really important for the purposes of just making sure there's a guaranteed service. And if a particular consultant is off sick, for example, then someone else can take their place. So that's absolutely crucial. Also important is that there's no guarantee on minimum volumes. Yes, you can specify sessions, but there's not a guaranteed payment amount based on volumes of work built into the contract. The trust should have limited control and supervision over consultants. This goes to the evidencing the fact that when the consultants are providing these services, they're not doing so as employees. They are simply being contracted to provide a service. And the recourse that the trust has is not through close line management and control of the consultants as it would do for employees, but rather it's through its contract. And it's the recourse is to go through the contract and say this service is not up to standard. We need you to do X, Y, Z. Really importantly, as I mentioned before, there's a transfer of risk to the supplier. So the LLP is assuming financial risk. You know, if it needs to invest in training, for example, of consultants or equipment that it thinks it needs that the trust can't supply, then that's something the LLP needs to go out and do. And operational risk as well is what I've just mentioned, the fact that the trust will hold the LLP to account for operational service delivery. And just a final one, as you would expect, the consultants, as I've just said, are not working as employees when they're doing their sessions through the LLP. They're just being contracted to deliver the service, and then self-evidently they are not receiving employee benefits either during that period. So all of those things, together with everything else I've talked about, just go to demonstrate that you've put this arrangement on an arm's length basis, and it's a robust and an appropriate contract to award to a supplier, and that they can then provide the service through this arrangement. So I think that is the last slide. Does anybody have any questions?
I think there's a question in the chat, Jamie, from Lee Tarrant.
Hi, Lee. So would they need a separate RO? Potentially, you mean in terms of the CQC?
No, so a responsible officer, so somebody that's responsible for the medics. So their revalidation and appraisal. So they can't be part of the employee body, and they have to be at arm's length. Would they have to be set up separately with a separate RO, or would they have to feed into the existing RO?
Sally, I don't know if that's something you've come across.
Let me just turn my camera on. But we tend to say that if the staff are working in the trust, that they can adhere to the trust policies and procedures and governance. There is the governance sort of lead for the LLP tends to be the chairman, and if there's any issues in the trust, that would be with any individuals, that's fed back to the LLP, and then those consultants aren't working, or they discuss that. But they tend the RO would be the LLP lead, but they adhere to all the mandatory training, all that sort of stuff that has gone through in the trust.
Yeah, and I think that's is not the case that the LLP needs to kind of replicate absolutely everything that the consultants get through the trust as employees. So things like that, I think, are dealt with through the trusts
It's just if you
arrangements with the
identified it
consultants.
and said employee benefits, well, that's a benefit of being employed directly with the NHS, is that you get an RO and it's free for your revalidation and appraisal. If you work for an agency, you'd have to pay for that benefit.
I mean, I think Jamie was referring really to employment benefits, sort of sick pay, holiday pay, that type of thing, rather than benefits of working with the trust, which can be documented within the contract between the parties. And I think it comes back down to things like, can the LLP use the facilities of the trust? As long as it's documented in the contract and the same with that, then it's okay.
But it's a good question and worth, worth speaking to the trust RO around that. We can always follow up as well.
Okay, I think there's a couple of questions around working time directive compliance.
I'm just thinking, you've got consultants who are on their contractual sessional work. They'll be doing work at the LLP. How do you ensure that compliance is adhered to, that it doesn't? There may be situations that arise where that may start to break down.
Sorry, I didn't quite catch the question, actually. Were you talking about whether the consultants need to adhere to the work time directive?
Yes, if they're doing sessional work at a trust, their normal agreed contractual terms, and then they're doing work outside arm's length with an LLP, how do you ensure that they're not overworking? In other words, they could be not able to fulfill their primary role. It's making sure that they don't do any more hours than what they should be doing legally. Does that make sense from a quality and from a governance point of view? Does that make sense?
Yes.
I've had examples in the past where people have been doing their full commitment, and then you find that they're actually doing extra work as another trust, and they're not really fit for purpose to do their primary role. So it's how do you make sure that legal framework is adhered to?
I mean, as part of the members' agreement, it states that the members all need to ensure that they're working fully in their standard, in their substantive NHS post before they do any LLP work. If there's something that anyone is concerned about, that needs to be raised with the LLP chair and looked at. The consultants can do private work anyway, and I'm not aware, unless correct me if I'm wrong, anybody, I'm not aware that there's a restriction on the amount of private work they can do, but they do need to adhere
no, there
to
isn't, and I've been in private healthcare myself. No, it's from this arrangement would be an arm's length arrangement. It puts us in a different ballpark. So they're doing their substantive work, they're doing extra, which is different to private work. Private work, they can do what they want when they want. But this is a different arrangement, isn't it?
I mean, Jamie, do you agree that it is NHS patients, but it's from their income perspective and their time, it's actually their private time? So there's no restrictions on what they can do, even though they have to be adhering and meeting their NHS requirements of their substantive role first.
I think it's, I mean, this is clearly NHS work. I think I would defer to an employment colleague. So when we circulate the slides, I'll send you a quick line about this point, because I'm not sure it's entirely straightforward.
No, it isn't. Thanks, Jamie. It's just a thought, thinking ahead, that there issues may arise where we need to have something done, and then it could start tipping over. You know what I mean? So that they're doing a lot more than what they should be doing from a safe point of view and a quality point of view. But thanks for that, Jamie. Thank you.
I think there's a question from Julianne about whether the LLP would be a designated body.
So I think that's relating to the revalidation point, which we've covered. So I think no. but to be discussed with the trust.
And I think that's just a comment from Lee, isn't it, about that last conversation. Okay. Anyone got any further questions for Jamie and Sally? No, I'm not seeing any hands. Okay, if that's it, then it should say future. Oh, Dillis. Why would you expect a medic to opt out? It would not make sense to do so.
Yeah, okay, we'll come back on that.
Okay.
Well,
Okay.
also we're saying if anyone thinks of any thorny questions that they forgot to ask, do let us know. We'll be very happy to answer them. We'll give it a day or so maybe before circulating the slides so that we can pick up anything else. And yeah, I hope it's been useful.
Oh, that's great. Thanks both. I really appreciate your time for today. Thank you.
Thank you.
Thank you.
Hi everyone. In terms of the rest of the agenda, hi Emma, I'm glad you've joined us. I think there was on there around providers and how providers are managing their different roles. I mean, you know, I don't know if anyone has got anything specific they want to raise at this point, or whether we leave that agenda item for the January meeting. I'm not sure if Mike has joined us yet. Mike Gill, come on. No, he's not come on, has he yet? What I'll do in terms of, I mentioned at the start that NHS providers are interested in GARNet members' feedback on this potential course. I will circulate Mike's email. So in terms of, you know, how he set out the course, etc. And if you could feedback directly to Mike, that would be really appreciated. Thank you. I haven't got any other business. I don't know if anyone else has got anything else they'd like to raise. No, I'm not seeing. No. Okay. The next meeting is scheduled. Obviously, I won't hold you to 10:30 if we've got nothing else to talk around, or you've got an extra 30 minutes. The next meeting is scheduled for the 25th of January. So as always, if you've got any thoughts, any ideas on what you'd like you know, the session to be focused on, please drop Al Whitfield, who's also on the call today, an email, and we'll obviously build that into the agenda, and hopefully Anne will also be back for the January meeting. If there's nothing else, just a huge thank you for everyone attending today, and I'll see you soon. Thank you.